Good morning. Thank you, Dr. Sabella, for the introduction and for the opportunity to speak again today. I entitled this lecture the 100-Calorie IBD Light lecture, or now for an IBD commercial, because if you come join us for grand rounds, we can talk for hours and hours on this, but you are here for a purpose. Primarily to pass that board or the recertification examination. So we're going to try to just touch on what you really need to harp on and to know for the test. If you have any questions, we'll be among you mingling this morning, so if you have any specific questions, we're more than happy to address those. Okay, so epidemiology of IBD in children and adolescents. Well, Crohn's disease rules. So if you're faced with a board review question, a test question, or a patient in front of you, and you're just banking on statistics, guess Crohn's disease, because it accounts for 60% of IBD in children, while ulcerative colitis accounts for 30%, and indeterminate colitis, where even if we have the colon removed and we can't tell the difference pathologically between the two, that only accounts for 10%. So remember, if it's a test question, patient in front of you, odds are it's Crohn's disease just by statistics. Crohn's disease typically presents in the pediatric age group between age 10 and 20, so in the second decade of life. And during the boards, the questions are fair and they're thoughtful typically, and they will give you a patient, not that's 5 years old with GI bleeding that's Crohn's, they will give you a patient who's not even probably 10, but they'll be 12, 14, 16 years old. So just bear that in mind, the age does matter. Well, what causes Crohn's disease? So we know that there's immune dysregulation at the core of it. So we think that there's three major components. So there's a genetic predisposition in these patients. So we'll talk a little bit about the hereditary factors later in the talk. But know that most patients do have some genetic tendency toward Crohn's disease. Then there's some sort of environmental trigger, whether it's a viral infection, whether it's a social stressor, some type of illness, something sets off the immune system so that there's abnormalities. And we call it that the patient then becomes under friendly fire, so that their immune system recognizes part of them, specifically some part of their gastrointestinal tract, as the enemy and causes tissue injury. So genetics, there's been a lot of research into this area, so we now know that there's over 160 distinct susceptibility loci for inflammatory bowel disease. Clinical evidence of a hereditary component comes from the fact that there's up to an 80% concordance rate among monozygotic twins. So if one twin has it, 80% chance the identical twin will have it as well. We also know that there's a 20-fold increased risk of IBD in first-degree relatives of patients with inflammatory bowel disease. Genetic syndromes also have been linked with an increased risk of IBD. So on the boards, you have to know sometimes that Turner syndrome is associated, so the 45XO. So if they give you a female patient, they describe the patient as having Turner's-like features and with rectal bleeding, suspect that the patient has IBD. Also, Hermansky-Pudlak syndrome has been associated. So this is oculocutaneous albinism, typically inherited in autosomal recessive fashion with platelet dysfunction, bleeding diathesis. Also, von Gierke's disease, so glycogen storage disease type 1B has been associated with the development of inflammatory bowel disease. Well, Crohn's disease. So as far as disease distribution goes, it can occur anywhere from the mouth to the anus, typically in a skipwise fashion. Ileocolonic disease accounts for 50% of the location in our pediatric population, and perianal disease occurs in 50% of patients. So we tend to tell the fellows that there's only two reasons if you see a patient with GI complaints for not doing a rectal exam. Number one is if you don't have a digit, and number two is if the patient doesn't have an anus. So it's really important to do a thorough examination and look for any evidence of tags, tears, fissures, or fistula. All right, so you'll sometimes hear us categorizing Crohn's disease when we send consults back as three different phenotypes. So either inflammatory, stricturing, or penetrating. That describes the behavior of an individual's Crohn's disease. So inflammatory, we're talking about, this is like the classic aphthous ulcer inside the bowel. Normally your intestines are supposed to look like the inside of the cheek of your mouth. So nice and pink and smooth. But here you can see that there's diffuse redness, and again, the aphthous ulcer right there. You'll see it, again, a transmural patchy distribution of the disease, and on the biopsies, the classic finding is a granuloma. Stricturing disease refers to when the Crohn's disease over time starts to narrow the inside lumen of the intestine. So as the intestine heals from an exacerbation of its disease, sometimes the disease can cause a narrowing of the inside lumen where you end up over time getting bowel obstruction or strictures. And then penetrating disease refers to when the disease is so active that it branches out and connects to other areas. So you can have disease where the intestines connect to other intestinal areas, causing an enteroenteric fistula. The intestines can also spring off and connect to the vagina or the bladder, or even to the outside, so that you see fistulous openings around the bottom or even at the belly button. So it's important to look all over your patient if you suspect Crohn's disease, because there may be other areas of leakage or opening. All right, ulcerative colitis. So the inflammation is typically continuous. It starts at the rectum and extends proximally in an uninterrupted pattern. So they're going to give you a patient with proctitis, typically on the exam, that has rectal bleeding and gotta go. So has to get to the bathroom in a very quick fashion. Proctitis alone accounts for 15% of these patients. Left-sided colitis explains 25%, and pancolitis, where the disease starts at the bottom and extends in an upward fashion involving the entire colon, accounts for 60% of our patients. And you can see a difference in the endoscopic view. So when we look at these patients, we can't always tell the difference, but oftentimes we'll see, Oftentimes we'll see a diffuse disease distribution where it just really looks diffusely erythematous. You don't see any distinct ulceration, but it's diffuse hemorrhage, bleeding, and pus. Right, what about presenting features to us in childhood? Certainly they can be mixed. We can't always tell based on disease presentation. But if you just statistically look at how the patients are going to present, a patient with Crohn's disease will most often present with nebulous abdominal pain, diarrhea, and weight loss. They'll have growth failure about 40% of the time. The ulcerative colitis patient, however, presents primarily with diarrhea, so it's like gotta go, because their rectum's on fire, and then rectal bleeding, so it'll be bloody diarrhea. They don't oftentimes have growth failure, as you see with the Crohn's disease, and they don't have as many extraintestinal manifestations. And typically on the board, they're going to be fair about it. So again, a Crohn's patient is going to be growth failure, nebulous abdominal pain, may or may not have diarrhea. The patient with ulcerative colitis is going to be diarrhea, gotta go, and they're going to have blood in their stool. All right, so what about extraintestinal manifestations? Again, it can occur in either patients with Crohn's or ulcerative colitis. Extraintestinal manifestations occur in about a quarter of our patients that we see, and it really is a systemic disease. So they can have musculoskeletal complications, they can have oral aphthous ulceration, anemia, biliary complications like primary sclerosing cholangitis. They can have pancreatitis up to 10% of the time, skin manifestations, which I'll show you, ophthalmologic inflammatory conditions, and also kidney stones. So oral manifestations, this is the typical picture that they would give you on the board or that you would be faced with in life. This is a classic oral aphthous ulcer, and it's surrounded by a red halo or an inflammatory base. These are observed in approximately 9% of our patients, and oftentimes the oral inflammation can precede by even months or years the intestinal inflammation. A lot of times it's a herald to they're about to have a flare as well. So it's always important to figure out what are your tell signs with your patients, so that if they say, hey, Dr. So-and-so, I'm starting to get my oral ulcers, just be very sensitive to, oh, this may mean that they're going to have a flare of their bowel disease as well. These are classic pictures, and on the board, they will give you classic pictures of conditions that you need to know. Both of these extraintestinal manifestations are more common with Crohn's and ulcerative colitis. We used to think that pyoderma gangrenosum was more oftentimes linked to ulcerative colitis, but it's really, they're both more common with Crohn's. This picture is classic for the erythema nodosum. So you'll see that there's diffuse redness and swelling. It can start off looking like mosquito bites, but if you touch them, they're warm and tender, and they're not pruritic. So I always ask my patients in between visits, have they had any episodes where it looked like mosquito bites, but it hurt, was warm and tender? They're oftentimes lower extremities, and oftentimes they'll start on the feet or the ankles and move northward. This is a classic example of pyoderma gangrenosum. Anytime you see anything black in the middle of a skin lesion, call your dermatologist immediately. It means they're very severe vasculitis, and the patient may need surgical debridement to get rid of that, and then in addition to very high dose IV systemic anti-inflammatory and autoimmune negating medications. All right, the ocular manifestations of inflammatory bowel disease. So these are the classic ones listed, but really what you have to know for practice, if you see a patient with inflammatory bowel disease that has any redness of the eye and hasn't been exposed to conjunctivitis, doesn't have any purulent discharge, any itching associated with it, or if this lasts for more than 24 to 48 hours, I always tell my patients, go see an ophthalmologist. At the time that they are diagnosed, we ask that they see an ophthalmologist just to make absolutely sure that that person's already on board and they can get in pretty quickly with them. All right, so other complications. So hemorrhage can be massive in these patients, so try not to get attuned in life to just hearing your patients with IBD talk about blood in their stools. Pay attention to volume and frequency. We've actually, unfortunately, had patients even bleed out with inflammatory bowel disease. Intestinal obstruction, like we talked about with the stricturing disease, where you've got narrowing of the bowel down. It can be a partial bowel obstruction with Crohn's disease, or colonic strictures occur in ulcerative colitis, sometimes even with rapid healing with our TNF-alpha inhibitors. Toxic megacolon is something that you probably hear us talk about, that it refers to an acute dilation of the colon. It is more common in ulcerative colitis. It is treated typically with antibiotics, IV fluids, and decompression. And sometimes the patient needs surgery to have a total colectomy because they have a high risk of intestinal perforation. In order to avoid that, we are strict about avoiding any medications that slow motility in the GI tract of our IBD patients or any patient that has rectal bleeding. So if you have a patient who says, oh, Dr. So-and-so, I've got lots of diarrhea, I've got lots of blood in my stool, but I'm going on a trip, do not tell them it's okay to take Lomotil or any kaopectate or anything that might slow down their gastrointestinal tract, and also narcotics. So even though they're having pain, narcotics are a high risk too for development of toxic megacolon. Perforation, so we talked a little bit about that. If you have Crohn's disease, it's typically more of a localized perforation, oftentimes in the right lower quadrant, because remember again, you have ileocolonic disease. And then toxic megacolon, like I just mentioned, ulcerative colitis, you can have a perforation essentially anywhere if the dilation of the colon is severe enough. And then abscesses, that's a complication that we know way too well in inflammatory bowel disease. It typically presents with fever, pain in the abdomen. It can be diffuse or localized. And it's more common in patients with Crohn's disease. Oftentimes they'll have the isolated perforation, right lower quadrant, and come in with a right lower quadrant abscess. So really have a low index of suspicion in these patients and a low index of suspicion for getting an ultrasound or CT scan if indicated. All right, so how do we diagnose patients with IBD? Well, it's always history, physical exam, as you know, with any other condition that you see. We combine that with laboratory evaluation, appropriate x-rays, and endoscopic evaluation to look for the histologic findings. In clinical history, again, like we talked about, ask about abdominal pain, diarrhea, blood in the stool. You're going to want to ask the history of, do you have any extraintestinal things, like fevers that you can't explain, fatigue, weight loss over time. Ask about those extraintestinal manifestations. Some of the rashes that if they're gone and they've forgotten about them, they'll leave you with a hypopigmentation if it's a dark-skinned individual, or the opposite, if it's a person of color, they may have changes in the coloration of the lower extremity. So pay close attention and ask them why the color changes. I also ask, it's very important again about family history. We'll see that over half of these patients will have a primary relative who has already a diagnosis of IBD. All right, so general appearance of these patients. Sometimes they appear pale. They may look fatigued or tired. Nutritionally, you're going to want to review that growth chart in every which way. So you want to look at their weight, their height, the trends, and the BMI centile. HENT, you're going to want to look at the conjunctivae, again, looking for those ocular changes. Ask them about prolonged tearing or episodes where they have days in which their eyes water or are red. You're going to look for the oral aphthous ulcers of Crohn's, so do a very good mouth examination. Again, examine the abdomen, look at the bottom. Remember, if you don't have a digit, somebody else on that can do it for you. Extremities, look for clubbing. So Shamroth, I don't know if you've heard of Shamroth's angle. So there's a South African cardiologist many, many years ago discovered that we should all have a diamond of light if we put our thumbs together. So I want everybody in the audience go like this. Look for a diamond of light. If you can't see through a diamond, then it means that you've lost your angle. We're supposed to have an angle between our nail and our cuticle of about 165 degrees. And he discovered years ago, and it's because he had cardiac disease, that he lost that, and he had hooving up of his loss of his angle. So what that represents, we call it clubbing. And clubbing is common in GI disorders. In our field, it's common in any malabsorptive process, such as inflammatory bowel disease. But it's also common in patients with cardiac disease or lung disease as well. But it's a good way to look for chronic changes of osteoarthropathy if you suspect untreated inflammatory bowel disease. Also look for joint deformity. Talk to patients about range of motion. Do a good physical exam that way. And again, look at the skin for any rashes or changes. All right, this is an example of what they're going to show you on the board as far as a growth chart. So again, they're fair on the board. So they're going to pick out a patient looking for either isolated growth failure as a presentation. They may say that the patient looks fine, doesn't have any complaints, but this is their growth chart. And then they may give you the family history if somebody has complaints of abdominal pain. What's your diagnosis? So what you're looking for here is that if it's a GI condition, typically the weight's going to fall off first and then followed by a downtrend in the height. Certainly, they sometimes ask, what is the most common cause of growth failure? In patients with inflammatory bowel disease, it's not malabsorption, it's not the medications that we prescribe. The number one cause of poor growth in patients with IBD is decreased caloric intake. And that is a common question that they'll ask you on the boards. And the reason that this is true is because patients with IBD know that if they don't eat, then they don't have as many symptoms and they don't hurt. So we'll have patients come in that they'll skip breakfast, they'll skip lunch, and they'll only eat when they're in the comfort of their own home because they know that once they eat, then they'll start having stooling or having abdominal pain. So they'll avoid eating in order to avoid symptoms, and it's really sad. But just, you can sort of figure out your patient by looking at the growth chart and seeing if they're able to make up for calories. And if they're really having symptoms and active inflammation, they usually can't make up for it. So you'll catch them. All right, so laboratory evaluation. The labs that we typically start off with are just a blood count looking for anemia or an elevated sedimentation rate. We look at the nutrition panel, inflammatory index, and stool studies. Again, we're looking for anemia, the high platelets, low albumin, elevated sed rate or CRP. We look for occult blood. It's present about 35% of the time, so it's not overly sensitive. And then you've probably come across a new test. It's been around for more than a decade in research studies, but it's clinically available. And I give Dr. Hubert, your next speaker, a lot of credit. She recognized years ago that looking for fecal calprotectin or even lactoferrin, which are looking either for white blood cells or white blood cell breakdown products, does significantly help you identify patients with active inflammation. We think that the calprotectin is more beneficial for looking for patients that have colonic inflammation, but I've had patients where it's been elevated that they actually ended up having either an appendicitis or H. pylori. So if that test is negative, it is reassuring, but again, it doesn't rule out inflammatory bowel disease of the small intestines by any means. And also, it's important to ask if you're going to order a fecal calprotectin, you want to know what insurance they have because not all insurance companies will cover it. The test costs between $500 and $800 depending on where where your lab is, where you work in this country. So it's not a cheap test, so don't take it lightly. Maybe have them check with their insurance companies before you order it. And also, if you're going to order a fecal calprotectin to look for intestinal inflammation, make sure that you have them turn in a first morning stool because that's when it's the most concentrated in the stool. And also, you want to make sure that they don't have any other conditions that would put white blood cells in the GI tract. So you want to make sure it's not during prime allergy season, so that they're not having a stuffy, runny nose, or that they haven't just started school and have like a cold or cough or sinus infection, because that'll give you a false positive if they're swallowing white blood cells. So try to get it when they're at their happiest from every other standpoint, respiratory-wise. Ask them for a first morning stool and absolutely have them check for insurance before they turn it in because it is not a cheap test if they have to pay out of pocket. All right, so antibodies, I'm just going to skim over. They're not going to be on your test. You've probably seen tests or panels. Maybe people have come to your clinics or your office and said, hey, why don't you start ordering this? It's a great test to screen for inflammatory bowel disease. These are different antibodies to different components of bacterial parts. And basically, P-ANCA, more associated with ulcerative colitis, ASCA, more with Crohn's disease, OMP-C, also more associated with Crohn's disease. None are diagnostic, none are 100%, and it's not recommended currently that they be used as screening tools because they're as much as a colonoscopy is, price-wise. So just be careful with what you order. We've had physicians in our region already kicked off of insurance plans for ordering too many tests or ordering everything that they know how to order. So be very thoughtful in what you order and just know that this is not currently recommended. Nobody in our group is going to use this as a primary screening modality for looking for inflammatory bowel disease. All right, so radiologic evaluation. So there are different test options. Upper GI small bowel follow-through is falling by the wayside. It is trailing off of the boards. It was on there as of a few years ago. Not sure that if it's still on there in the cycle of questions. But if it were, and it's still there, and sometimes that happens, the most common abnormality on an upper GI small bowel follow-through is going to be TI nodularity. Other findings, you may see a narrowing or separation of bowel loops when you look at this study. CT enterography and MRI enterography have become much more popular and more well accepted in the past 5 years or so. So CT enterography is useful in identifying bowel wall thickening or abscesses. MRI enterography is increasingly used for small bowel imaging and looking for extraintestinal manifestations as well as perianal fistula. And the great thing about it is there's no radiation involved. It's just that it has to be done after both tests, after they drink a significant volume of contrast. So neither of them can be done when the patient is sedated under anesthesia. So these tests are not real practical if you have a small child that you're looking for inflammatory bowel disease because of the lack of ability to sedate them for it. All right, so this is an example of what would be a classic test that they would show you on the board for an upper GI small bowel follow-through. So what you're looking for, typically you want to see barium go all the way through the intestines. It should be an even pattern, small bowel and colon. The interesting finding here is that, everything's filled out sort of over here, but you have this little strand of barium going through on this side. So that means that the strand is going through the tiny, narrow lumen, and that the areas that are dark and separated are thickened bowel that can't fill with barium. So this is a classic example of what a radiologist back in the day, and in some institutions you don't have MRI enterography yet. So this may or may not be on the board, but just so you know, even if this were a screening scan for an MRI shot or a CT, it would look the same. This is a cut through a CT enterography, so a more current study looking at inflammatory bowel disease, and this is the classic finding. Again, you've got this very thickened bowel and this little tiny narrow area in between where the contrast can get. The contrast is the darker area, and these are more representative of normal bowel wall. The septum should be very tiny, thin, and over here on the right side, very thick. And you can tell where you're like, oh, where am I looking at in the body? Because we're not radiologists. So just know that this is a bone. These are pelvic bones. So if that helps orient you in any way, this is the back, this is the front. So again, this is looking at the person, this is the right lower quadrant. So that would be classic for a patient with IBD. They're not going to give you something left lower quadrant in a kid with Crohn's disease on a board. It's going to be right lower quadrant abnormalities on any imaging study. All right, so barium enema. This is a test that used to be done commonly, but all this is to show you is the lack of features in the colon. So over time with ulcerative colitis, you just become a hemorrhagic tube, losing all features, and it just looks like the old terminology was a lead pipe. So it's just straight, featureless, unhealthy chronic disease. All right, endoscopy. So endoscopy permits observation histologic sampling. It helps the gastroenterologist pay for their kids' education. So we encourage that. No, but it's actually necessary to visualize what's going on inside the bowel and to get tissue samples for analysis. Again, it's going to be pretty obvious. I showed you on the ulcerative colitis disease starting at the rectum, moving north, not skipping any areas. Whereas with the Crohn's disease, you'll have segmental involvement. So it's going to skip. There'll be areas that look healthy to the naked eye, healthy on the biopsies. But also areas of disease. And then we take a lot of time in our practice to make sure we get through into the terminal ileum and take biopsies there, looking for disease beyond the colon to confirm that, yes, it really is Crohn's disease. Also granulomas, we're looking for those on biopsies, but those are there less than 20% of the time typically, so it's kind of frustrating for us that we can't always give the person the diagnosis when we walk out. And then also we do the biopsies because we can look with the naked eye, think everything looks fine, and then the biopsies will be abnormal and diagnostic. All right, so video capsule endoscopy or small bowel capsule endoscopy. We have patients, one of my talks today is about foreign body ingestion. Well, sometimes we as gastroenterologists feed patients foreign bodies. So we feed patients this 11 by 26 millimeter plastic camera, and it takes 2 pictures per second as it travels through the small intestine, so through the gastrointestinal tract. The battery that's associated with it, they wear a battery pack on the outside. After they swallow the pill, it beams pictures to this little pack that they turn in at the end of the day. We don't want the camera back, it's disposable. It's like a $600 disposable camera. But at the end of the study, we're left with an 8-hour DVD for our viewing pleasure to look at their small intestine. So if you want to know what Dr. Mahajan's doing after 5 p.m., a lot of days it's reading an 8-hour DVD of somebody's intestine. But this is a really neat way that gives us a look into an area that we couldn't otherwise see unless we subjected them to small bowel enteroscopy, which are very long scopes. Those tests take up to 3 or as long as 3 or 4 hours, require general anesthesia, and you don't always get all the way through the gastrointestinal tract. So this is certainly something that we do prior to subjecting them to very long endoscopic procedures. But this is just a picture of what it looks like in the small bowel, and it's even if they have, and I had a patient last week that had suffered for probably 4 or 5 years, had multiple EGDs, multiple colonoscopies, normal MRIs, normal CT enterographies, and her pill cam looked just like this. So she had classic Crohn's disease of the small intestine, diagnosable no other way but by this, or by very long push enteroscopy. So don't forget that if you really suspect organic disease, keep going with it. But she had actually been admitted on a psychiatric ward for months and had no diagnosis, and it was kind of sad. All right, nutritional therapy. So we talk about therapy for IBD being nutritional, medical, and surgical. Nutritional therapy, we tend to get a dietitian involved with our patients to make sure that they get enough calories, that they catch up with their growth. Lactose intolerance occurs in about half of our patients. They are subject to small bowel bacterial overgrowth too that may contribute to their symptoms. Specialized diets have been studied, so the specific carbohydrate diet, use of monomeric or polymeric formulas, you'll see us use those. In some cases, these diets can be as effective as induction therapy with steroids. But it is a difficult diet for a lot of people to comply with, and so oftentimes that's why you don't see us necessarily prescribing it with the frequency you would think we would. It's just very difficult for children and adults to comply with. We do look for and consider potential nutritional deficiencies, so dysregulation of calcium, vitamin D. You'll see us doing bone density scans looking for osteopenia. If we have them on certain meds, we look for certain deficiencies. So we supplement them with folic acid if they're on sulfasalazine or methotrexate. We also look for fat-soluble vitamin malabsorption if they have extensive TI disease, as well as B12 malabsorption. And then we consider other micronutrients. Medical therapy. So typically on a board, they're not going to ask you exactly what therapy you should be using, but just know that antibiotics are a low-level option, 5-ASA products as well, corticosteroids we use for induction therapy, and then our primary maintenance treatments are immunomodulators, including azathioprine and 6-MP, as well as methotrexate. Biologic therapy you've heard a lot about in the past decade, TNF-alpha inhibitors is listed, and the newer anti-integrin antibodies. If it's on the board, they want to see that you're selecting things more toward the top of the screen than toward the bottom of the screen as an option, but I haven't yet seen any you being asked on a general board as to which is the appropriate therapy for an IBD patient. Rescue medications, just in clinical practice, that we may use as a bridge to either surgical considerations or one of the other meds include tacrolimus, cyclosporin, and thalidomide. All right, steroids. What you need to know is they're not recommended as long-term therapy because they're not good maintenance meds. I always say they're your friend in time of need, but they're your enemy long-term. So side effects are guaranteed with steroids. The response rate initially can be up to 90% for UC and up to 78% for Crohn's, but it's not a persistent thing. So the effect will wear off and the side effects set in, and then you get yelled at as a doctor for what has happened. Side effects are dose-dependent, and alternate day therapy tends to lead to fewer side effects than every day. Those are the side effects listed. Cosmetically, acne, it can go either way. Facial puffiness sets in, hirsutism, striae, the stretch marks that never go away. Chronic administration also leads to growth suppression, cataract formation potentially, glaucoma, hypertension, bone and muscle issues. Azathioprine, or 6-MP. These are immunomodulators that are used to reduce and eliminate the use of steroids. Response rate is good. In ulcerative colitis, 78%, over 90% in some patients with Crohn's. The duration of action, though, is slow, so it takes 3 to 4 months to see the full effect, so you have to overlap them with your steroids. So we have steroids at a higher level, weaning, and we have these medicines building up. They are effective as maintenance medications, and complications that we talk about with our patients are pancreatitis. So this could be a board question for you. So they may list the medication as azathioprine 6-MP for treatment of Crohn's. Patient comes in with horrible epigastric pain and vomiting. What lab are you going to order? You're going to order a lipase because pancreatitis is associated with this medication. We also follow patients closely looking for bone marrow suppression as well as liver toxicity. So you'll see us ordering labs and monitoring them. TNF-alpha inhibitors, so infliximab or adalimumab, one's IV, one's sub-Q. They both block the inflammatory effects of TNF-alpha. Potential side effects, allergic reactions. That's why the IV version's giving in centers. Closely watch for an infusion reaction and treat it accordingly if it develops. They may develop new or worsening psoriasis. We check them on a regular basis for TB to make sure they haven't acquired that because they can develop miliary TB. And if they are exposed to histoplasmosis, that's a big problem. So I tell them they can't be around bird or bat droppings. If their whole goal in life was to be like Batman or be an aviary specialist or spelunker, they need to come up with a new career choice. If they're going on a field trip, they have to wear a mask to protect themselves from inhaling any spores or bird or bat dropping aerosolized spores. And then hepatosplenic T-cell lymphoma, you've probably heard about that. The highest risk are males under the age of 35 who are on both TNF-alpha in addition to azathioprine or 6-MP. Vaccinations, what you have to know is keep vaccines up to date. We like to vaccinate our patients prior to starting this therapy, and they need to avoid live vaccines once we've started it. So I always tell them they can't have an intranasal flu vaccine, and they have to talk to their pediatrician, make sure there's nothing live being given. Surgery. So surgery is curative for ulcerative colitis. So they do an iliopalchainal anastomosis. A satisfaction rate in our patients here at the Cleveland Clinic is very high. We follow a large population, both pediatric and adult, who have had pouches. Surgery in Crohn's disease, not curative. All right, so let's do some quick questions, and these are common ones that you need to know. So all the following are true about Crohn's, except inflammation may involve any part of the GI tract, growth failure is common, surgery is curative, or it is the most common form of IBD in children. So which one's true, not true? All are true except. Good job, 97% got that right. So yeah, so surgery does not cure Crohn's. So if you operate on this, so if Crohn's is from here to here, and the surgeon takes out from here to here just to make sure they got it, puts the person back together, 100% chance it'll be back. Usually it's within 3 years, but within 10 years it's 100%. So it is not curable with surgery. All right, maintenance therapy for IBD includes all the following drugs except. So what is not a maintenance drug for IBD? Is it mesalamine or other 5-ASA products, steroids, azathioprine 6-MP or mercaptopurine or methotrexate? So which one is not maintenance? Correct. So B is the right answer. So steroids are not maintenance medic. They're, again, friend in time of need, enemy long term. Too many side effects, can't stay on them forever. All right, and next question. Which of the following is or are characteristic of children with ulcerative colitis? A perianal disease, hematochezia, granulomas on endoscopic biopsy, melena, or both A and C? So what goes along with UC? So good job. So the majority you get that right. So blood in the stool. So ulcerative colitis, remember, it's going to be proctitis. Their rectum has to be on fire for the diagnosis, and then above that can be. So it's blood in stool and gotta go. So bloody diarrhea is classic. They don't get perianal disease with ulcerative colitis. Granulomas are the ones that go along with Crohn's disease. They can have melena, but it's classic that it's bright red blood per rectum. All right, good job. So I'll see you guys in a little bit. I think you get a break at some point, though.